area that was very interesting and maybe hasn't gotten as much attention as it's due discussed at San Antonio was the use of bisphosphonates as anti-tumor agents in early-stage breast cancer. There was an update of the ABCSG12 trial by Michael Gannant that looked at survival, and now they have updated and mature survival data in this group of 1,800 premenopausal women who had sort of medium risk disease. About 30% of the patients had node-positive disease and 20% had grade 3 histology. They didn't receive chemotherapy, but received ovarian suppression and were randomized to tamoxifen or anastrozole. No difference between tamoxifen or anastrozole, maybe a little better with tamoxifen, and I think in many people's experience, less side effects. So we learned that from the trial. They only got 3 years of therapy, and they're still doing really, really well with many years of follow-up, well over 6 years. And that's very encouraging for us in terms of the efficacy of hormone therapy in ER-positive disease. But patients were also randomized to receive zoledronate or not, the potent IV bisphosphonate, and they received it every 6 months for 8 doses, essentially 7 or 8 doses over 3 years. And they see a survival benefit in the women receiving zoledronate, less recurrences across the board. And what's interesting is comparing that to the data from Rob Coleman from the Azure trial recently published in a sort of a panoply of patients, a very heterogeneous group, high risk, receiving chemotherapy, and also getting zoledronate, but more frequently. And I think what that shows us is that there's some interaction with causing ovarian suppression or menopause, because in a subset of the Azure trial, women who'd been in menopause for at least 5 years, they also saw a benefit. So that's not proof, but it's very encouraging with the ABCSG12 data and some data also presented from ZOFAST that the bisphosphonates may have a significant anti-tumor impact when you select patients who have essentially none of their own estrogen and are on drugs that can cause bone loss. And it may be that causing bone loss creates an environment where cancer cells can grow, and that by giving the bisphosphonate, you alter that environment and really make a significant impact in outcome. So I thought that was very exciting, and I think it does encourage us to consider bisphosphonate use in premenopausal women who were receiving ovarian suppression along with hormone treatment with tamoxifen, and in postmenopausal women who were receiving aromatase inhibitors as their primary therapy without chemotherapy for metastatic disease, and who've been in menopause already for long enough to have a risk of bone loss.